improving GP access has been on the local and the national agenda for a number of years. Back in 2022, we carried out 2 projects to explore this, a website study and a hot topic where we collected people's experiences of making GP appointments. Both of these reports are available on our website in case if you're interested in having a look how things were back then. In 2023, NHS England published their delivery plan for recovering access to primary care, following which, in 2024, there were 430,000 more appointments delivered by GP practices across the Nottingham and Nottinghamshire ICB footprint. Furthermore, the new GP contract for 2025-26 mandates more reforms. Our aim was also to monitor how local progress is keeping up with this evolving national policy landscape. For this project, we collected data by making telephone calls to GP practices and carrying out reviews of GP practice websites. The first round of data collection was carried out in July 2024 and the second round in May 2025. In the report, you can find the full list of practices which have been contacted, but there were a total of 57 practices contacted across all the 4 place-based partnerships and primary care networks in Nottingham and Nottinghamshire. We now move on to the findings, which we have grouped under 2 major sections, GP access and website reviews. But in order to give you a better context, I will also present the recommendations relevant to each set of findings alongside them, rather than at the end altogether. Access to GP services. We evaluated this by looking at 2 primary booking channels, telephone and online, with our aim being to get a broader picture of how accessible GP services are in effect, both in terms of reaching the service and securing an appointment. We noted the call waiting times in the morning hours, as this is a key indicator of telephone access. NHS England has also identified the 8 a.m. rush as the most critical pressure point in general practice, and managing this has been the target of the NHS England 2023 recovery plan. In our study, we found that 2 out of 5 practices answer their calls within 5 minutes. However, 1 in 5 have a waiting time of over half an hour. The wide variation in times is clear from this plot, with the shortest wait being less than a minute and the longest one being over an hour. This clearly illustrates that call handling capacity at peak hours varies significantly, demonstrating ongoing pressures on practices, which ultimately impacts patient access and experience. The next indicator that we looked at was digital telephony. A shift to modern digital telephone systems was a central tenet of the NHS England 2023 recovery plan, which was designed to assist GP practice staff and improve patient access and experience. We evaluated this based on the caller's queue position being stated and a callback being offered. 86% of the practices offer the former, whereas only 38% practices offer to hold the caller's queue position and call back. This is our first recommendation, that we recommend this functionality is fully utilized to improve patient experience and match up to the NHS England vision of modern general practice. Moving on to the telephone booking hours. Allowing patients to ring and book appointments at any time during the practice opening hours is a crucial strategy to alleviating pressures during the 8 a.m. rush. While 68% of the practices reported that they accept appointment booking calls throughout their opening hours, they also added that they encourage patients to call early, as the appointment slots are limited and often fill up fast. Ultimately, the patients have to be then asked to call the next day. Our second recommendation, therefore, is that patients should be allowed to book appointments throughout the opening hours, and this has been mandated under the new GP contract, which has come into effect as of this month. Next, we explored the online access to GP services, starting out with looking at the ability to book appointments online. 81% practices enable patients to book appointments via their website, as was reviewed during the website investigations, whereas 68% practices give patients the option to book via the NHS app, which was asked during the telephone calls made to the practices. Since nearly 1 in 3 practices do not support appointment booking via the NHS app, we recommend that all practices uniformly enable this function. This is crucial to support the shift in the NHS from analog to digital as per the NHS 10-year plan. The other marker we looked at under online access was the stated response time to online requests submitted via the practice website or the NHS app. Over half of the practices respond on the same day, in line with national expectations, and 21% have a response time of 2 to 3 working days. The remaining 25% present a gap in digital access. Our next recommendation, therefore, is that practices respond to online requests promptly and consistently to build on public trust in digital channels. In order to understand the accessibility of appointments from a patient's perspective, we also assessed a few different parameters. The first was the choice patients have in contacting their GPs, and the results can be seen in the chart here. While all practices can be contacted by telephones, 86% offer the choice of being contacted online, and 79% of the practices offer walk-in appointments. Overall, it was seen that 68% of the practices offer all 3 modes of booking appointments, that is, phone calls, online, and walk-ins, and are fully compliant with NHS England guidance. However, nearly a third of the practices limit this offer. We recognize that digital methods help to manage the huge number of requests, whereas the non-digital methods are important to ensure that access remains equitable, because it is often the most vulnerable members of the community who might need to book walk-in appointments. People who are excluded due to their access to digital services or due to their lack of, devices and internet. We therefore recommend that all 3 booking methods are uniformly available across all practices. During our study, we also looked at the choice of appointment type that patients are offered: face-to-face, telephone, or video. 81% of the practices reported that they offered patients the choice of whether they wanted to be seen face-to-face or talk to a healthcare professional over the telephone or a video call. However, it was also pointed out that the final outcome often lied with the healthcare professional carrying out the triage. We have heard from patients time and again about not being able to see their GP face-to-face, and this has shown to impact their experience and satisfaction, which can ultimately affect health outcomes. Therefore, we recommend that patient preferences are honored unless there is a compelling clinical reason which suggests otherwise. We'd also like to acknowledge that one of our GP colleagues has raised that this recommendation does not match with the patient charter, which was released in August, which says that your practice will decide what is best for you based on your clinical condition. We do not want to contradict any clinical guidance, and if there is clinical reason for a particular course of action, that should, of course, remain as the main consideration. What we do wish to recommend to our system partners is that patient choice is taken into consideration, especially in an instance where a patient wishes to be seen by their GP face-to-face rather than speaking over the telephone or over a video consultation. The next criteria that we looked at was if practices offer advance bookings for routine appointments. 88% of the practices that we researched offer this. However, we found that the booking windows can vary widely. They range from 48 hours to up to 3 months. This is an important issue or an important consideration because, it is an important consideration so that patients are not asked to call back another day as mandated by the NHS and also stated in our new patient charter. Next, we move on to the second section of findings, which focus on information available on GP websites. We started by looking at the information on the websites about how appointments can be booked and managed. The majority of the practices explain the general booking process. However, only 73% explain a difference between an urgent and a routine appointment and how to book each of these. Whereas only 59% provide information on the triad system. That is, if a patient will be assessed by a clinical staff before they're offered an appointment or the next course of action. Only 1 in 5 practices include an indication of the expected response time to online request, leaving a majority of the people without this essential information. We feel this is important to highlight as this may deter the utilization of digital communication channels. Moving on, 78% of the practices include information on the variety of healthcare professionals at the practice available other than GPs. And since it's a common theme which is raised with us, we also wanted to highlight that while 70% of the websites confirm that face-to-face appointments are available at the practice, this has come down from 91% in 2022. That was our research which we conducted in 2022, where we found out that 91% practices explicitly state that face-to-face appointments are available. Some other accessibility information that we looked at and we feel was important is publishing clear information about services such as home visits, chaperones, and interpreters, because it is a key way to improve the accessibility and help patients to self-navigate their care. 90% of the practices provided information on home visits, whereas around half of the practices only provide information on the chaperone details or interpreter services. National guidance also sets out very clear expectations for improving the usability and accessibility of GP websites. It recommends that every GP website should include 3 key pages: appointments, prescriptions, and contact information, with each offering clear guidance on how and when to use digital and non-digital channels. 95% of the practice websites that we looked at provide clear information on these 3 key pages. National guidance also highlights the need to accommodate diverse language needs by providing translation tools to support patients whose first language is not English. 88% of the practices do have a translation tool available. However, it was found that the usability and the placement of the translation tool varies. Language options are not always similar, and the positioning on the web page may affect the usability of these translation tools. So our final recommendation around website clarity and accessibility is That GP website should clearly explain the triage process, the expected response time, and the availability of services such as chaperones and interpreters. Accessibility information can be improved by offering translation tools that are easy to find and use. Consistent layouts across websites in a template which NHS England recommends would also support a more intuitive user experience. We originally recommended that we would like a patient charter to be available on all practice websites, and we know that this has now been released. We welcome the new patient charter, and we hope that this will empower patients with the information that they need and deserve. Thank you.
Thank you, Asra. So we have here several representatives of organisations which will definitely have an opinion on our report. So I wondered if first I could turn to Michael Wright from the local medical committee, perhaps to comment on what he's heard so far.
Thanks, Richard. Yeah, okay, so just to say, I mean, I'll put it in the chat, but so our role is representative body for GPs across Nottinghamshire, and we work with all of the practices involved in this. So I think it's I think the timing's interesting. So this feels to me like this work has gone on over the kind of last year or two at a time when practices are bedding in new contract changes, and we've seen more coming last week around online consultations and information. So there's a lot to grapple with, and at the same time, practices also were moving over to new telephony systems. So I guess for me, there's two things that really come to mind reading this and again listening to this, and there's something around there's a bit of a mismatch between what the government wants to see in general practice and what general practice is currently able to do. So the variability is well known to us, and I guess if you've always been in one practice, you might not understand quite how much variability there is. But for the most part, you know, practices are small businesses. They run themselves in the way that they see fit. But more and more we're seeing adoption of good practice, or, you know, so for example, the websites are starting to become much more standardized in a lot of practices. So the NHS has put money into support for practices to use a common template, which would then be potentially updated centrally, and then the right info would be there. So there's this struggle really, which I think is changing, about the variability at practice level versus what can be done at scale to help with communication. So that's going to grow, I think. But ultimately, there's some really good ambitions in this 10-year plan from the government. The problem we've got really is that it's how capable practices are to step up to do that. So we shouldn't see any more of the 8 a.m. being told to phone again the next day. That shouldn't be happening anymore. And that should be discussed with the practice. If that's happening, we should we should have a discussion openly about how we can avoid that, because that shouldn't be happening now. But the fear at the moment is that, you know, we're in this position where a lot of practices are just maxed out. They're just trying to keep going, and the headline figures from the government about investment don't equate to money going into the practice at practice level. It tends to be for different schemes around general practice. So I'm not making any excuses for where things should be better. I'm just saying that for many practices, and we've got 126 across Nots, for still many of those, their own sustainability is under threat, and they're worried about how they're going to carry on. And we've got this crazy situation in Nottinghamshire where we still have GPs who are unemployed or underemployed, including GPs coming out of training every summer, because the practices can't afford to bring them in. So the work is there, the need for more support is there, but at the moment, the funding for a lot of practices isn't sufficient to get that extra support. So inevitably, whatever route we open up for people to get appointments or contact the practice, it still relies on the capacity of the practice to service it, as it now will with online consultations, which need to be on throughout core hours. So there's some really useful points in there. The recommendations all make complete sense. And I'm sure that the commissioners with ourselves would be keen to look at some of this and to help support practices. But I guess I'm putting it in the context of everything that's asked for extra is against a backdrop of practices that just can't increase their capacity to deal with it. So we have to keep working a way to try and find ways of improving the care that's given. But it's in a really difficult time. And I'm sure it will improve over time as we get more used to the contract changes and how best to navigate through them. Sorry, Richard, that's quite a long answer, but
No,
that's my overall take on where we're at.
Thank you. Thank you very much, Michael. You mentioned commissioners there. I know that we have in the meeting Stuart Newman, who is, how shall I put it, the Deputy Director for Primary Care Transformation.
Yeah.
Stuart, would you like to comment?
Yeah, sure. Thank you, Richard. I think it's sort of similar or echoing probably quite a lot of what Michael said. So I think there's a sort of thank you for producing this report. There's a lot of really useful information in there. And we have sort of taken and reviewed the recommendations. As Michael said, there's been a lot of work going on in practices to look at their access models, how they offer access and what they can do to improve that. And I think the overarching position is that as you've got in your report, we have seen appointments go up year on year, and they're going up again this year in terms of what practices are delivering. We're also starting to get some positive feedback from patient experience surveys that people's experience of access has started to improve. It's probably not where anyone would want it to be, but it's definitely on an upward trajectory. And the other thing that we look at is the sort of timeliness of people's routine appointments, and we've seen that improving over the last 12 months, so that now we're hitting the national target that 85% of appointments are delivered within 14 days when people contact the practice. So as I say, there's been a lot of work going into it, and all of that work takes place at practice level, and we are starting to see some improvements. I guess in terms of the other bit, as Michael said, we have been through it in a period of flux when new systems are being introduced into practice, and that's not going to change in the next 12 months with the new requirements about online consultation. But I guess in terms of the particular recommendations, the issue about callback features. So all practices should now have a telephony system that enables patient the callback functionality to be switched on. So we are and continue to work with practice to enable that. In terms of the enabled appointment booking throughout opening hours, as Michael said and you've alluded to, there is a requirement now for online consultation to be available throughout core hours. That does present challenges for practices. A lot of practices have been looking at new access models and using online consultation to sort of help reduce the 8 a.m. rush, and that has been successful. But there are some challenges around opening that up throughout opening hours. But we sort of continue to try and work with and support the practices to see how that can be delivered in a safe and effective way. And again, there'll be more ongoing discussions at a national level, I think, around that. In terms of the recommendation around responding to online requests promptly on the same day, that is now a contractual requirement, and as I say, is subject to ongoing discussions about how that can be delivered safely. So meeting obviously the patient desire for a response on the same day with the practice's ability to deliver safe and effective care, and not find themselves with unsustainable workloads. There's a lot of work gone into deployment of the NHS app and also increasing the functionality on the app, but recognising that the app can't be the only front door into the NHS, and that we do need to sort of make sure that there is still the ability to contact practices via the phone and by walking in. I think you've talked about the offer all three types of appointments. And as I say, our belief is that most practices will do this. There will always be a sort of dynamic where what the patient needs may be different from what the patient's able to deliver, or what the patient wants to do. But we do think that generally the practices do try and honour that, the people to be seen to have the access they want, whether that's face-to-face, telephone or video. And then in terms of the website clarity, again, as you've said, there is now a charter that needs to be on all all practice websites, and we've been working with practices and an external company to review and standardise websites as far as possible across Nottingham and Nottinghamshire. So again, that work's continuing through the next financial year. So you should see that there is increasing clarity and also standardisation of practice websites over the next 12 months. So I think, yeah, in summary, there's been an awful lot of work around primary care access. We are starting to see some evidence of improvement, but again, there is a lot more work to do.
Thank you, Stuart. Helen, I see you've got your hand up, but I'm trying to say, if I can come back to you in the question and answer, if that's okay. But yep, you've definitely marked your place as the first person for the question and answer. So the last person I particularly wanted to bring in today is Alison Hogg, who is head of comms at Digital Nottinghamshire. I think actually a perspective from digital access would be quite interesting. Alison, are you happy to talk?
I can do. Yeah, hello everybody. Nice to see you all. Yeah, so just for those of you that don't know, so Digital Nots is the digital transformation team for Nottingham and Nottinghamshire ICB. So we work across the system, we work closely with colleagues within Stuart's team and others as well around many projects, but I guess here today around the NHS app. We lead on work around the NHS app. And Richard knows that I found the insights and this report really insightful. I think, to echo everything that's been said before, it was really interesting and great to see, the responses and things like that. I think we've done a lot of work, and colleagues continue to do a lot of work in Nottingham and Nottinghamshire to we were on the front step, really, on front foot with regards to the use of the NHS app, and that which has evolved over time. But we recognise that there's more to do. I think, and it is obviously an exciting opportunity to keep hearing how the NHS app is going to play a significant part in the changes to the NHS over the next few years or so. I think one of the things that we would really recognise locally is about making sure that whilst digital access to GPs and things like that is suitable for certain people, it isn't suitable for everyone. And we work very hard with colleagues and very hard within the localities to make sure that we run digital support hubs, and we've got specific team members out there who can support patients and colleagues who need to have more confidence in using the NHS app. I think the other thing that's been happening more recently, obviously that move to online consultations, we welcome that. We know that it can play a significant part in mitigating against the 8 a.m. rush, and we know that there are some good case studies becoming more evident of practices who have already moved to total triage and other systems, and that is having a significant impact both on colleagues within the practices, but also patients as well. So I think it's about how do we harness all those opportunities, share the good practice, but also about making sure that we can work together and to support communities and individuals who need more support. And how do we do that? So that is what I think we'd say at the moment, Richard, I think.
Fantastic. Thank you very much, Alison. I mean, I was just tempted to add at that point, actually, that of course one of the challenges which Healthwatch recognises is we can make the changes, but we've got to carry the public with us so that they understand what is changing. And I think that has been one of the difficulties. As an example, in terms of callback, talking recently to patients, some people at this stage don't trust callback. They don't trust that they are going to get callback. Interestingly, those who did use callback said, yep, it works absolutely fine. It's a really good system. So we need to try and get that message out there to help people understand, yes, it is different from when you were younger, but actually it should be more responsive now. We are running a little ahead of time. I'm very pleased to hear that, because that means we have more time for questions. So can I call on first Helen Miller, because she did put her hand up first for your question, Helen.
Thank you. Yeah, I guess I'm going to like to make 2 points, 1 point and a question. First of all, to endorse what you've just said, Richard, I think some of the issues that patients have is that there is a mismatch between what they perceive our communication promises, that a lot of the things that are very actively being implemented now perhaps should have been in place about a year ago, and the public don't understand that perhaps we're setting high targets just to get the movement. Sometimes they think when people stand up and say we're going to deal with the 8 AM rush by autumn 24, that's what they mean. So just to sort of support Richard on that, but the question I really wanted to put, I think it's certainly to Alison and Stuart, possibly to Michael as well, is I get the point that GP practices are kind of independent businesses, and they've got control over a number of their own issues. But the contract and the ICB do control quite a lot of what GP practices do, some of which, to be fair, don't entirely make sense to patients, but I'm sure they do to you. But one of the things that really frustrates me at the moment is that I've got an excellent GP practice, but they've been allowed to adopt a triage system that doesn't actually link to the NHS app. And given all the other things that they have to do, why couldn't that have been put into the contract that you don't launch triage in until it links to the system, the software links to the NHS app?
Who would like to respond to that point?
I can respond a little bit on the contractual bit, in that the contracts, the main contract that each practice has is a national contract, so it's basically it's not local to the ICB. In terms of the technical bit about how different systems are selected, I couldn't answer that. If Alison can't, I can take it away and can come back with a response if that's helpful.
Yeah.
I think I can give give you our perspective in that, Helen, we would share some of your frustrations as well, if we're honest, and that there seems to be a little bit of a disconnect there, it would appear, from at a national level, systems that can be chosen for total triage, but they're not already integrated into, or it's going to be on the roadmap for integration, and that is one of the things that we share a frustration about, if I'm honest. But at a local level, I don't know that there's, and Stuart will know more, but from a Digital Knots perspective, we can't influence that. That is out of our control.
These systems are selected at a national level, is that correct?
They're put on the system. You can
choose from them, selection.
Yeah, absolutely.
Yeah.
At a national
so again,
level.
this is another patient frustration. So we raise an issue like this, and it's a national contract, it's a national selection list. Raise it with NHS England or other national bodies. Oh well, the ICB have got control about, or it's a local GP decision. You know, patients really don't know where the accountability lies here.
Yes, thank you, Helen. Yes, Michael, do you want to add anything to that?
Do I? I don't know. I think sometimes what happens here is that when you get any new idea comes out, there's a whole slew of companies who suddenly start marketing to practices to tell them they can do this and do that. One of the latest ones is transcription services using AI. And then often the practice gets quite interested, they get promised the earth, and then they get told, actually, you need to go through these contract methods, or you need to get this checked and get reassurance. So the telephony one was interesting. You said about the callback facilities, etc. So the telephony one was a national contract change, and practices had to move across if they weren't compliant with their systems, and many had systems that were quite in quite a while, but they didn't necessarily have the callback facilities. So in a sense, when they move over, that's when you might see a rise in the callback facilities being available. But yeah, I think this follows a pattern where we sometimes see innovation go ahead of the contract change, and then the contract will then, say that the use of the NHS app is much more, it feels it's much more in the last 12 months that this has been really driven. And obviously West Streeting's very keen that so much is done through the NHS app. But this is after the case of when a lot of this has been put into practice. So we're doing it in reverse in a sense. So I think this is why you'll see inconsistency. What we hope to get to, of course, is that we all help our practices to get better connected with the app where it makes sense. But I think that's why there's variability, because often the contract change for the practice comes after the new tech is already in place or is being trialed in practices. So it's not quite joined up in the way it ought to be at all times.
Thank you, Michael. Anne, you've been very patient waiting there with your question.
Now, the NHS app, a lot of people would like to be able to access the NHS app, but they can't because they haven't got a passport, which is no more than a year out of date, nor do they have a driving license, and they probably have never had either anyway. So there are three things that they are, it's alleged that they can actually get from their GP surgery, but I can tell you that I was unable to get them, right? These three things are the linkage key, which could be called passphrase, the ODS code, which could be called organisation code or practice ID, account ID. Now, my GP surgery, the secretary spent a long time, the whole of their lunch hour actually, with me, trying to provide me with all of those. They could provide me with the linkage key and the ODS code, but not the account ID, because like a lot of other people, I was not registered online. Now, I'm quite happy to register online because I have got the internet, but there's a whole load of people who are digitally excluded and increasingly digitally excluded. Now, I was advised to write to Paul Miller, Paul Miller, the head of IT at the ICB. I haven't had an answer yet, but I'm hoping that somebody can sort out the fact that there are an awful lot of people who are going to be increasingly left behind because they can't actually get onto the NHS app to use it. They would like to, but they can't get onto it.
Alison, I think that perhaps would be, yes, a fitting one for Digital Nots.
Yeah, it's Anne. Hello, Anne. Yeah,
Hello,
I'm sorry to hear about your experience, and that's not what we want to hear. Interestingly, I was on a meeting, a call yesterday where we were talking about registrations for the app without photo ID, and it's recognised, there's a lot that needs more to be done with awareness with the reception teams about these ability to provide patients with these codes. And so there is training available that is readily available to practice teams that's coordinated by NHIS or technical training providers. And one of the key things that they do pull out is the ability to provide patients like yourself with those three passcodes to enable registrations for the app. What I would say is locally, or we've been trialing a specific campaign within a particular PCN area to highlight the ability for patients to register without any photo ID. And we know that that's been successful, but it does it does, for it to be successful, it needs to work with the practice teams and the reception teams to know that they can make that happen. So what I would say is happy to maybe try and take it offline, and if we can get hold of your practice details, I'll see whether there's anything that we can facilitate in getting you online and getting that sorted for you.
It's interesting that you mentioned their training, because when I phoned my surgery, and I have a very good relationship with my surgery, by the way, they didn't know what I was talking about, right? So they said, well, come up and we'll try and sort it out.
Yeah.
So we all sat together, all four of us, for an hour and a half, I think much longer than their normal lunch hour. And they desperately tried to help, and they were very frustrated because they said, we can't crack it. If you can find somebody who can crack it, please get back to us. I haven't found anybody either. No, but basically, yes, but I'm sure that my surgery is typical of a large number. And this is, I think, the frustration that Helen also alluded to, that basically everything is so fragmented. Not everybody knows everything. Some people know some things, some people know nothing. A few very lucky people know everything. But for goodness sake, we're talking here about life or death in many cases. So everything should be joined up for everybody, not just if you are vocal, you can go and, ask and find out, but everybody should be able to access everything. Yep. Anyway, thank you very much. So if I give you my surgery details afterwards, yeah. Fine.
We can
Thank
make
you
sure
very
that
much
details
for
are
that.
passed on, Anne, if you...
Yeah,
Will
make
you-
sure you pass them to Richard direct. Don't share them to Richard, and then Richard,
Right,
if you're happy, then Richard
okay.
can share them
Yeah.
to me.
Right.
Absolutely.
Thank you very much. Thanks a lot.
Thank you. And just to say, Michael has added in the chat that if there's a simple fix for this, then sharing it in an easy to understand way with practices would be great and can be pinned up on the wall at the front desk. I think that to a certain extent, it feels like there's a role here for Digital Knots and for the Integrated Care Board to perhaps work together to make sure that there's a nice, clear set of instructions that can be shared with all practices. Because I know perfectly well, no practice wants to deliver a bad service.
No.
Thank you, Anne.
So could I ask you to lower my hand because I can't do it myself?
Of course.
Thanks.
Now, the next person with hand up actually is Julianne Gray from Highcroft Surgery. I'm not sure. Julianne, are you around, or is it...
Hi, Michael. Yeah, I can't get my camera on. I do apologise.
Don't worry, that's fine. That's it.
But I am here. So my point leads really into what Anne has just mentioned. And my concern is with the NHS, we had a funded, person at some point come in for a few months into the practice, sit in the practice itself, and people could go and, go through how to access the app. They'd get them registered, they'd get them on, they'd show them around, how to use the app and everything else, all the facilities there, which was really, really good. That funding only lasted for, sort of short term, it's a few months, and then obviously the funding was pulled. And now it's all, sort of down to reception, who haven't really got the time capacity or the understanding of the app themselves to sit with people, and certainly not spend, sort of hours with them trying to get them logged on, and, sort of still not achieving that. So I'm just wondering, obviously, we're almost sort of shooting ourselves in the foot here. Why can't we just have some funding ring-fenced again to have, somebody sit in the surgery and just be there to facilitate people accessing the app? Because a lot of my patients are, of the older generation, and the 80 or 90-year-olds, once they're on the app, they understand it, they can access, the results, they can access, sort of the consultation notes, follow up, they've got appointments. So it is a barrier for people if they can't access this, and literally just relying on reception in a GP practice, when, our receptionists, from the minute they sit down to the minute they leave, are constantly on the phone, you know, sort of care navigating, signposting, and there's not a minute they've got to spare, you know, other than, you know, sort of care navigation and reception. So that's my sort of point really, is you know, why can't we have the NHS app trainers come back, because it's so key to this.
Thank you, Julianne. Who would like to comment on that?
Could I just say that there is the community hubs in Gedling are getting their act together, and they're actually helping. There's something called Tea and Tech, which runs at the Carlton Community Hub every week, right up until Christmas, because it's right that there was a gentleman called, I think, Mr. James Smith, I think his name was, and I met him once at a Carers Roadshow, but then when I got in touch with him, he was no longer, as you say, no longer funded. But I think the communities are starting to help people themselves. But again, you see, that's part of the whole fragmentation. So some communities have things like Tea and Tech, right? But not every community has that. So again, we're back to the whole thing about a lack of equity of access.
I can see, Alison, you were keen to come back on that.
Yeah, no, it was just to observe, to say, yes, I think the roles that Julianne were referencing were the digital inclusion coordinator roles that had been, there were some that were funded within individual PCNs. That funding was made available, I think, for a couple of years, in the hope that having had it done centrally, that then the PCNs would take on board those roles and look to fund them themselves. I know that that hasn't always been the case with every single PCN, which is why then I think the James that Anne mentions, he was in post, and unfortunately the funding for that role was no longer continued. But we recognise absolutely that those can be key roles for supporting both patients but also the workforce. I think there are moves afoot now to see whether we can get something done at a place-based partnership level, but I'm not quite sure how on the timescales of those. But again, we're trying to see whether there's something we can do that can sort of bridge that gap. I do come back to, but we would also encourage colleagues that there is internal staff training around the NHS app as well, so that we want everybody to feel more confident when discussing the NHS app.
Thank you, Alison. Just to say actually that Michael commented that this supporting role to provide advice to patients on how to get onto the NHS app might be something that a patient participation group could actually help with, which is certainly an interesting idea. Helen rightly points out that, of course, systems are fragmented, and so it can be complicated for people to offer that advice. And I think actually, yes, it's the usual one of it takes time to build up expertise and the variability that you encounter to be able to offer to people, okay, well, this is how you do it. Abdullah adds, actually, thank you, Abdullah, about perhaps this is a role that social prescribers could play. And certainly, yes, it would seem to me that would be quite a logical role for a social prescriber to be able to offer somebody. Kate comments actually loves the Tea and Tech in Gedling. There's definitely lessons to be learned there. Joe Brown, interesting discussion. The NHS 10-year plan is suggesting libraries for this, but that is another discussion in relation to where libraries are open and when, and it is always about people being able to get there, which will exclude a number of people as well. Helen finishes us off with patient participation groups, social prescribing, place-based partnerships may all be able to help, but without the training that needs to be funded, the accountability lies with NHS, which, yes, I think that's a fair point. Can I actually call on Stuart at this moment, actually, just to sort of say, from the ICB's perspective, the challenge around the NHS app?
I think I haven't got a lot more to say, to Alison. I think there is some effort about putting some resource to support digital inclusion in neighbourhoods as they develop. But yeah, there isn't anything really to add beyond that, I don't think, at this time. So we don't, the support that we offer is through the Nottinghamshire Health Informatics Service, which Alison comes from. We basically have a relationship with them to provide that support. We don't have anything else that we can offer directly from the ICB, because we're essentially a commissioning organisation.
Yes, understood, Stuart. Joe Brown actually raises an interesting question. Stuart, there might be will the ICBs be looking at digitalisation within the new neighbourhood health services?
Yeah, that's kind of, I think, what me and Alison were saying, where the digital inclusion workers have gone. The idea is to put some resource back into the development, into the developing neighbourhood teams, to have that as part of their remit.
Thank you. Yeah. And Kate raises the question, what tailored support is offered to healthcare and practices that have more problems with access? And what's the profile of the communities they serve? In other words, is there some awareness of which communities are perhaps struggling more and where perhaps more help is needed? Alison?
Yeah, I can answer that. So yeah, we as a team do look at the app registration stats for each practice, and we'll tailor support according to that. So we're absolutely mindful of that. And for example, I was just about to post in the chat a link to a website where, as part of Get Online Week, we are hosting digital support hubs within GP surgeries to try and encourage and support patients to get more use of their app. And these have been specifically looked at and chosen because of their low registration numbers as well. So we are absolutely mindful of that approach as well. We're also trying to look at the materials that we send out to practices as well. And again, making sure that they are targeted and with practices that have slightly lower registration rates. So with, absolutely, we look at that data.
Thank you, Alison. My colleague Astra did make a little interesting point about, obviously with support, there are concerns around data privacy for NHS patients. And interestingly, in a piece of work that we did alongside Digital Knots pre-COVID, we actually had one of the issues which was recognized is some people are very happy to have other people assist them in accessing services, but some people are very keen to say, no, I don't necessarily want my carer to see everything that goes on in my NHS records. Michelle, you've waited very patiently. I apologise, it's taken a while to get through to you. Please go ahead.
That's no problem at all. So I'm Michelle Boxer. I'm a practice manager in Clipston. And it was just a few things really, kind of echoing some of the IT integration frustrations from a practice perspective, and often what's sort of promised to us as practices. One example being the registration forms, going online and being able to now register, and that supposedly being an integrated process to make it easier for patients and make it easier for practices and to save time on administration, and that's not the case. We're often these things often do not line up, both for practices as well as for patients, and creates a barrier because the patients as we are the point of contact for the majority of contacts with patients, they expect us to know, and we're either not informed, we don't receive the information about the issues in terms of registering, like with the links that Anne was talking about. So it creates a barrier in itself for frustration between practices and patients. With the NHS app, again, it kind of very often feels like these are things that the changes are done to rather than with a lot of healthcare. And coming back to the changes that have just happened on the 1st of October, that practices, we've got to kind of remember that practices are not trying to be a barrier or put barriers in place. The reason we're here is to support and help patients. The fundamental issue is capacity. You open an online consultation work stream, that means that the access is then limited for appointments via telephone or via walk-in. There is not an infinite resource, and it's a really challenging fit for everybody. But it's not because the practices don't want to offer it. I'd love to be able to say to everybody, yes, you can see a GP, yes, you can see the GP that you want to see when you want to see them. And it's not a realistic ask, unfortunately, especially when there's no additional investment for us to be able to do that. But often, like Alison was saying about the training from NHIS, the NHIS offer in terms of training is great, and it's available for practices, but things move along so quickly. So you can do the training, but in 6 months, 12 months time, that training's out of date, the information's out of date, the staff members no longer with the practice. It's really difficult to keep everybody. And we've got a team of 50, that's changing constantly. We have 3 rotations of GP registrars and trainee doctors moving through our practice in a 12-month period. It's the turnover and the change is huge, and trying to kind of marry that up with the constant change within particularly technology and the moves forward is really difficult. But last thing I was going to say is the disconnect in terms of communication as well, because even with the October 1st changes, there is this interchangeable use of online booking and online consultation, which is very different. And that's an issue because practices are following a contract that has been very clearly specified and very strict in the way that it's been implemented, but what's being messaged out to patients and the media articles that I've read and I've seen through the BBC and through local news about online booking of appointments, that's not a reflection of what is actually being asked of practices. So it sets us up to fail straight away. So yeah, it's really difficult dichotomy all the time of trying to balance the reality with what's actually being offered out, I think.
Thank you, actually, for that, Michelle. Certainly, yes, I can recognise that public messages are garbled by media, unfortunately. Would any of the other colleagues would like to actually sort of comment on some of the points that Michelle has made there? Fair enough.
Sorry, I will just say for Michelle, I think actually, despite the level of criticism that it feels, where patients do recognise that GP practices, everybody wants to do the best job and they do care for patients, and beyond GP practices, the whole system is populated by people who want to do the right thing. But actually, yeah, I agree with you. It seems to be constantly set up to fail.
Thank you, Helen. Michael.
Yeah, I'm trying not to get political, but it is all about politics as far as I can see. This is about vote winning, and this is about doing things that look really flashy, and that the government have turned back years of not doing the right stuff. So they're very good, and we should vote for them. The online consultations, as Michelle says, is really confusing. It's really the wrong name for it in a sense. So the big things we've got problems with just on that are, just to give context, You've already had the online booking anyway. That's been a function for quite some time. But the online consultations, this could be that you've got a medication request or you want to ask about your health problem or whatever it might be. It's not really about online booking appointments, although that's what the press have really carried last week. So the problem we've got here is that anybody at any given point could just sit there at 6:20 in the evening and go, oh, I'm interested to know more about this, or I'd like to know what my GP thinks of this. And then the practices are meant to respond in the same working day, which is crazy because it's going to shut in 10 minutes. So this is one of the problems. And the other part is just that it's very hard to see at the moment. There's no safeguards at the moment to stop people putting urgent requests on there. So it could be an urgent problem that somebody puts on there. That's why you can't really afford to not look at it promptly, because it could be the most innocent thing. Can you get a form signed, please? Or it could be something major urgent. It's just that the patient's chosen that route to do it. So there's no safeguards in the system at the moment to help us to make sure that we keep people safe. And I'm really interested in the point in the chat that Kate's made about continuity of care. I think most practices really care about continuity of care and think it's valuable. I think all of these initiatives are about getting access, irrespective of continuity of care. Just get access, just get through. And actually, it's the misnomer. GPs are one of the most accessible professional groups you can get. It's just actually getting the appointments you want at the right time by the right people. That's what we struggle a bit with. But access itself isn't the right word on this one.
Thank you, Michael. Yes, just for those who haven't seen, actually, Kate has raised actually the question of rapid access is important, but we also need to support continuity of care, which is particularly important for those with long-term and chronic conditions, as continuity of care has been shown to improve health outcomes. How are we balancing these? Would anyone like to comment on that? I agree. Stuart.
I think this is, as Michael just said, I think this is one of the things that practices are really trying to do on a daily basis, is balance the demands of getting everybody in as quickly as possible with providing continuity of care and potentially longer appointments for patients that really need it. I think it is a real challenge, and I think from an ICB point of view, probably I think our focus will probably be a bit more around the promoting more continuity of care than it is around access, but we are there is obviously some national political imperatives around that. We have tried to do something around this by providing a kind of an additional contract and additional resource to practice to provide some continuity of care for selected patients where we think this would be of most benefit. But it's a drop in the ocean really as to I think where we probably should be. But it's a step in the right direction, but we've got a long way to go.
Thank you, Stuart. Yes, I think I think part of the challenge here is, of course, is communicating this to the patients as an entire body of this is what you can reasonably expect. We are still running slightly ahead of schedule. Does anyone else have any more questions or observations that they would like to make at this stage? I'll give people a moment to compose their thoughts. Well, it comes up as Alan, apparently, but yes. Yes. Yeah, the person with their hand up, you can say it's coming up as Alan Wells, but
yes, that's me.
Right.
I'm just thinking here about the CQC inspections. We've not talked about them at all. It would just be interesting, the link between the results and how each practice is being measured by the CQC. Was that a daft question?
Not a daft question at all. It is obviously something as well that Healthwatch has some role to play, insofar as very recently we were asked to go into a GP practice to assist the Care Quality Commission on an inspection, with the logic that we are the experts at talking to patients. So there is, yes, we are practically intercalated with some of the work that the Care Quality Commission does, And as people may well be aware, of course, the way that the Care Quality Commission is operating has changed significantly and is still changing. Would anyone like to comment on the role of Care Quality Commission and how this feels for general practice? Michael, thank you.
I'll jump in before maybe some of the practice colleagues might want to say. CQC, where do I start? Okay, so it's interesting what we've seen. We've seen a change in emphasis from the CQC in the last year in particular. So COVID kind of played havoc really with this in terms of the way they did their inspections and kind of followed up with phone calls, etc. I think it's a really hard job. You're basically asked to go into a practice and spend a day there, and within that one day you're meant to get a feel for how good it is on a range of things. One thing we were told was that, so it's a little like Ofsted, you get the 4 ratings, outstanding, good, requires improvement, and the last one, which is basically special measures, and we just have this thing where we were told that outstanding was going to reduce. We were actually told openly that they were going to reduce the number of practices that were called outstanding. The targets would be harder to reach to get there. The threshold would change. So it kind of feels a little bit like, which is very upsetting for people if they feel like they're an outstanding practice and then they see a change on that when they work so hard. CQC is a difficult one because it's just, it's a snapshot in a day in a practice, and I think when there's serious problems, they will normally get picked up anyway. And I think the ICB work on a bit more of a scorecard approach where they take the CQC ratings as part of how they would assess the quality of a practice. But yeah, my experience is it causes a lot of stress and strain to practices to prepare for CQC on the day with CQC, and often they get people who have maybe never met come into their practice and run riot around it, and they're sometimes quite disrespectful to them, and it's a very stressful experience. I would challenge how you could really gauge the quality of your practice based on a group of strangers coming in and spending a day in your surgery, but that's my opinion. I think the commissioners and other bodies have a lot more information and data, which includes patient feedback as well. But at the moment, that's the way that the previous government went, and at the moment we still have CQC, and they're pretty untouchable.
Thank you, Michael. Michelle, you popped your hand up actually on that one.
Yeah, I think it's from our perspective as a practice, CQC is there's always that sort of Damocles of that whole thing of, and in the same way as there is with Ofsted for schools, it's always sort of there and it's hanging over your head. And I think it's that shifting sand effect of never quite knowing if you measure up. Their framework is completely different. That's gone through a huge change, and just feeling that anxiety of being constantly needing to be ready for something coming is huge, and takes away, I think, from the actual delivery of care in a lot of ways.
Thank you. Comment from Julianne that from the clinician point of view, continuity of care is best all round. I endeavour to follow up all my patients with highly complex health needs. However, pressure is on to increase access at the detriment of continuity. We simply have not got capacity to provide everything to everyone. And in fairness, I would say patients, in talking to us, do recognise the pressures which general practice faces. I think mostly it's about actually what they want is an honest comment. What's actually going to happen for me? Alan.
It's Chrissy, actually.
Oh, right. Thank you. Yes, Chrissy. It's just your name is coming up as Alan. That's all. So.
Sorry, what are you asking me?
So you've got your hand up. So I was giving you the opportunity.
I was just trying to put it down there.
Not to worry, not to worry. From Stuart, actually, the comment actually, with CQC, the Integrated Care Board approach is generally to support practices to address the concerns that the Care Quality Commission identify and improve. Nationally, NHS England does use the CQC rating as one of the markers of practice performance. But perhaps that is fortunate to say just one of the markers.
Yeah, I think basically there's a whole load of practice indicators, and essentially the CQC rating is used as a kind of weighting measure nationally. As I say, locally, we're obviously really cognizant of the CQC ratings, but generally the approach is to work with practices as the LMC do as well, to help prepare for CQC inspections and get to the best place possible, and then obviously then work with practices when the inspections come back and there are findings to work on to then support the practice to address those concerns. So yeah, we're well aware of CQC inspections and the outcomes of those, but as I say, it's more of a supportive approach.
Of course, thank you. I'm just going to read a couple of comments actually from Julianne Gray. Please, can digital coordination coordinators be funded again to come into the surgery or attend community hubs, relying on receptionists who are really not the best place to take on NHS app support? I think, well, there's obviously been some discussion of where that support needs to come from. Certainly, as a Healthwatch, we can recognise that obviously reception is very, very stretched. I will say, in undertaking part of this study, one thing that really struck me, I didn't have the 77-minute call, but I did have an hour-long wait on one call, and I was just suddenly struck by, I've been sat waiting for an hour, but actually, from the point of view of who's answering that call, they've been working constantly for that hour. It is perhaps somewhat understandable that people can get a little bit tetchy in responding. For the point of view of the patient, this is the moment in which it starts, but for the reception staff, they potentially have been running on this for hours. Obviously, that doesn't excuse sometimes behavior, but it is perhaps understandable. I realize time is moving on rapidly. So Astra, do you have the little survey to pop into the chat? We would really like feedback from you on how we have done today. This is only the second of our stakeholder events that we've actually held. We are still trying to learn. So if everyone could perhaps fill that in, that would be brilliant. But I pass back to close now with our CEO, Sabrina.
Be good to come off mute. Wow. Okay. Well, I am blown away by this conversation. There is so much really in there. So first of all, I just want to say thank you all for your contributions and questions, and the thoughtful reflections that have been shared this morning. I've found it really powerful, and there's lots that I'm going to be taking away. I'm just thinking about what we've discussed around fragmentation, frustrations between patients and the practice, the NHS app, and how to access that adequately. There's lots of change going on. There's so many different moving parts, basically. But I think it feels like it's been quite a rich and honest discussion. So I really appreciate that. I guess as a Healthwatch, we are really committed to working alongside all of you to kind of keep people's lived experience at the heart of the discussion and at the heart of kind of the decisions that are being made. And I think, this piece of work really reflects kind of our ongoing role in amplifying those voices and influencing change across the system. I think it can be hard sometimes to remember that the end user, whatever is going on, whatever kind of confusion is out there, the end user is the one ultimately that we want to be able to support. And that has come across really clearly today, that that's what we all want. But there are lots of things, I guess, outside of our control as well that makes that a challenge. Our recommendations in terms of the report and the work that Azra has done and the team, I think they show, you know, that what we want is for there to be a willingness to collaborate, to kind of move things forward and you know, figure out what the solutions are and the answers, even if there are some small quick wins that we can identify when we go away back to our respective places. That would be really what we want you to take away. We value the work of, you know, we really value the work that GPs teams do every single day. We know that it's hard, but meaningful feedback is one of the most powerful tools, I think, for learning and improvement. So with that being said, I hope that we can stay connected. I hope we can, you know, you can connect with us as we monitor the responses and the progress that's being made in terms of our recommendations that we've made today in our report. You know, what we want is to make access to primary care more fair, more consistent, you know, more person-centered for everybody really in Nottingham and Nottinghamshire. So thank you all so much. Honestly, I'm so grateful that you took the time out this morning to join this conversation. And as Richard said, we have a feedback form. The link is in the chat. It's probably scrolled up somewhere, but if you can click on it and please let us know how we've done today, because we want to make sure that sessions like this are really useful and that we can improve on them all the time. So thank you very much, everybody.
Thank you, everyone.
I think there were some questions in the chat regarding if the report and the presentation will be shared. Yes, we will be sharing a copy of the recording from today's session with all of the attendees, and we'll also be adding it to our YouTube channel. The report is already available on our website. I will just pop a link into the chat, and we will also send it out with our thank you email so you all can have a look at it again. Thank you very much.
And sorry, there's also a question about whether or not it will be shared nationally. All of our reports go up to Healthwatch England as a national sharing, but are you talking about NHS England as well and more national bodies in terms of sharing nationally? Is that a question? Oh, you're on mute.
Yes, that was whether this would influence what is happening nationally, because obviously there are things that are bigger than Nottingham and Notts.
Yeah, we do. We tend to make sure that we try and share all of our reports on a national basis as well. Yeah. Thank you.
Thank you so much, everybody. Thank you for joining us.
Good to see you. Take care.
Thanks all. Take care. Bye-bye.
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 It's fighting.
Can't
It's
see the
fighting, and I
poll.
can
Can't
tell.
see the poll. Where's the poll?
Right.
Not the poll, the
survey.
survey.
I'll just put it in the chat once more for you. Just a minute. There have been a lot of messages that have come through after that. Yeah, there it is.
I can't see it, but I will just tell you that it was great.